వ్యూస్ యూట్యూబ్ ఛానల్ను సబ్స్క్రైబ్ చేయండి, మా వీడియోలను లైక్ చేయండి.
Okay, good morning, respected Ramdev Rao and my colleagues sitting on the dais. Actually, I could see this is more of the emotional function rather than the scientific function. The way, the foundation of this institute, auditorium, campus is all around, those emotional aspects of the family, great family of Raos, I really admire and compliment the, service, human service which they have started way back. So I think in that kind of, and of course, Kamlakar, of course, is my very, very dear and old friend. And it is his one word, I cannot say no. So I came. Now you can. So, in the keynote, I want to cover a few things because students are here in good number. So, let me say the healthcare scenario. What is the healthcare scenario in the country? Let me begin from that. Now, we present government, rather even the previous governments have been talking about implementing universal health coverage. So, you must first know what is the universal health coverage. Universal health coverage means providing health care to the population at the cost what they can afford. So it is not about the free health. It is about the delivery at the cost what population can afford. That is why most of the countries will have two or three segments. One is the below poverty line. To them they will give free. Above poverty line some subsidy, and of course the higher rich class they will have to pay of their own. So I think that is the kind of scenario most of the developed country or developing countries have to follow. Now in India, the AyushmanBharat scheme, I think all of you have heard about it. It was launched in 2018 for this very purpose, that 40% of population, because it is estimated at that point of time, I'm talking of 2018, that 40% of India's population is below poverty line. So that is the concept this scheme was launched, and I think 40% is covered by that. Another 8% population is covered by CGHS, another 4% covered by ECHS, and things like that. And recently, 70 plus population also has been included in the Ayushman Bharat. So if you add all these things along with 14% of the population being served by the private insurance, then we are touching somewhere 65% of population today has got some or other cover. This is not a small thing. 65% of population has cover for the health.
Doctor,
Okay, right. So I think this is the fundamental. Now, what are the component of the universal health coverage? Again, for the students, the four components are making healthcare available. Available in terms of number of beds, number of doctors, number of nurses, number of allied healthcare professionals, and of course, diagnostic laboratories or overall healthcare infrastructure. So that is the first component of universal health coverage, making healthcare available. Now, where are we now? As per WHO, you need 3 beds per 1,000 population. Fine. Now, how many beds we have got? As per the survey of 2023, after that, of course, number of beds must have rather increased. We had 2.1 million beds. 2.1 million beds, of which 1.3 million beds are coming from the private sector and 0.9 million beds are coming from the government sector, public sector, what we call. So, what you need is almost double the number to make it 3 beds per 1,000 population. So, I think we have long way to go to reach the goal of 3 beds per 1,000 population. That is about it. As regards to number of doctors, I think we already have got more than 1.3 million doctors available registered with the National Medical Commission. But the issue here is that unfortunately the MBBS doctors we do not really count practically for the purpose the way we are delivering the allopathic healthcare. So if you only take the postgraduate and above, the ratio is coming 0.65 doctors per 1,000 population. So I think we here also, I think the recent initiative by the government, various state government, each district is going to have one medical college, and number of PG seats also have increased now, almost touching 80,000. I think gradually, maybe after 3 years, you will be able to find that our country has got sufficient number of specialists to serve the community. Nurses also, again, number of schools and colleges here itself, we are running the school and colleges for the nurses. So that also number we are going to make very soon. So this is about the availability. Now, what about the accessibility? That is the second component of the universal health coverage. Now, accessibility means providing health care to the population within the practical reach. That means, let us say, the primary health care should be available, let us say, within the 10 kilometers of the range. Secondary, let us say, 30 kilometers of the range. Tertiary care, 50 kilometers of the range. This is a general, estimate, general, norms which is followed. Now, problem what is having today, I'll give the example of Telangana, let us say. Now, in Telangana, 100 bed and above, 100 bed and above are those hospitals which provide tertiary care. Now, how many are there? As per again 2023, we have 126 hospitals with the 100 bed and above. Out of which 118 are in the city where we are, Secunderabad and Hyderabad. So I think you can understand rest of the Telangana population have to travel to Hyderabad only for the tertiary care. So this is the serious setback for our country, and this data not only Hyderabad applies across. In Tamil Nadu, the 50% of such beds are available only in Chennai and Coimbatore. So I like that all remaining countries also have. One more study which we have done, which was submitted to the government, very important study, that what is the number of beds per 1,000 population in each state. So you will be really surprised. I will give you only the two data here. The Karnataka has the highest, 4.2 beds per 1,000 population. And which is the lowest? Which state has the lowest? Bihar. 0.3 beds per 1,000 population. So I think this is where is the diversification in our own country. So I think we have to work seriously to meet this factor of accessibility. Accessibility for primary, secondary and tertiary and quaternary care. That actually is a big project which government now has started after this study was submitted to them, because nobody bothered. For example, Delhi, let me tell you, we have actually nearly 5 beds per 1,000 population. But the question is, in Delhi, you will never find a bed available. Never find a bed available, because it serves patients from Bihar, UP, Madhya Pradesh, Haryana. All the patients come to Delhi. And that is where actually you are, the very poor factor as far as accessibility is concerned. The third factor is about the affordability. Now, affordability, as I told you, around 65% population we are providing care. But this is on paper. Practically, the problem is that 40% population I referred earlier through the AyushmanBharat or Arogyasri. Let me tell you that this combined state of Telangana and Andhra has got the distinct, I say honor, I will call it, that they started Arogyasri when 2007. You see, Ayushman Bharat came in 2018, which has been given a lot of, importance and publicity. But it was the Rajshekhar Reddy who started the Arogyasri in 2007. And I think I remember that gentleman, Mr. Khan, he used to come to Quality Council of India. The kind of, the system he generated, the monitoring of the patient through this scheme was fantastic. But the problem is, gradually, both the governments, out of the populist move, they started inducting more and more, issuing cards to everybody. You know, I am told really 90% population in Andhra and Telangana has got that Arogyasri, or now of course names have changed, cards. Now fund is same, which was catered for 40% population, and now you are serving 90% population. That's why, this scheme is partly successful, partly failure. And many hospital in your own Hyderabad, they do not entertain the patient from these schemes. So that's why I said that practically we still have large population which remains unserved, and that is where the affordability still is an issue. So most of, I think, us at the government level or at the Niti Aayog level, we are trying to see how more people take private insurance. Now you will say, why you are propagating private insurance? Why not government funds are available to increase, let us say, 40% to 90% population for the rest of the country? You must understand, government gives 1.8% of GDP for the healthcare. 1.8%. Around 2.75% of GDP is coming from the private sector. So even if I make 3 plus 2, less than 5% money we are spending on the healthcare in our country. While global average means poorest country to richest country, the ratio is 7.8% of GDP. So with this money, you can't run the healthcare. Particularly, I'm talking of 1.8% of the government. So that is why I think we are encouraging people in the, population at large to take the private insurance, because otherwise we will run into problem in time to come. So this is the present status of the affordability. The fourth factor of the universal health coverage is known as acceptability. Okay, acceptability means in terms of standardization, quality, and things like that. Now, there in 2005, when we launched the NABH, now that journey, of course, is very simple. I will tell you again for the students that when I was occupying the position of Secretary General Quality Council of India, there was a question in the Parliament. It was in April 2005 that people were coming to India for medical tourism or medical treatment. One patient traveled all the way from USA and came to escorts for bypass surgery. I mean, things started that time. And these people started asking the question that how do we select a hospital? Do they have any accreditation system in India? And that question from Parliament came to Ministry of Health, and Secretary Health referred to me. I was occupying the position there, and that is where we started, the journey of, because healthcare quality accreditation is not like laboratory accreditation, because where in laboratory we have one standard, 15189 across whole world. But hospital accreditation follows a specific standard for each country. And then these standards are evaluated by International Society for Quality in Healthcare to give them the equivalence of, you can say, So that is where, we started developing the standard from April onwards. And, as usual, like Fauji, our Kamlakar is armed forces doctor. I choose who was supposed to come here, Air Marshal Pawan Kapoor. He should have been coming here, but he has gone out. So I appointed him as the chairman of the technical committee. He, along with 5 more doctors, developed this NABH Edition 1. And this Edition 1 was then submitted to International Society for Quality in Healthcare, and we got finally accreditation from ISQA for second edition. So this is briefly, one more aspect, let me tell you. When we launched the standard in 2006, there are hardly 36 applications in 1 year. Hardly 36 applications. Because people found what the hell it is. so difficult, why unnecessarily, and things like that. Now, after 1 year, only 5 hospitals qualified. And luck would have been they were granted certificate by then President Dr. APJ Abdul Kalam in a big function. And that I think spread the word. Oh, NABH is handed over by the President of India. And I think next year we got almost 300 applications. And of course, the rest is a history now. We have got, I think, total number of accredited or certified and, impaneled number is touching 25,000. So that means you can say 25,000 hospital nursing or impaneled. That means they follow some little or some kind of quality norms or what we call patient safety. So I think this is where we are. I think we are on the path of achieving universal health coverage in all the 4 segments. The target has been set as 2047. Now, one more little aspect I will tell you that why cost of healthcare is going up. Now, why the cost of healthcare is going up? I will give you one simple reason. In 1947, any one of the students can tell me what was the average life expectancy. Just guess what? What was the average life expectancy in 1947? 50. Okay, I think students might not have read this one. It was less than 37 years. Less than 37 years. Today, the average life expectancy is 73 years plus. So you can understand how this has happened. This has happened only because the advancement in the healthcare, diagnostic, technology, our doctors, qualification doctors, that is the way. Now, all these things, when they are happening, obviously it is going to cost. So I think I keep telling people that quality healthcare, which includes everything, will cost. But absence of quality may cost you the life. Only thing is we have to be prepared now that we provide some budget for our own health. Do not depend on only the government budget. Be prepared to have your own insurance. Otherwise, I think in the time of emergency, we may run into problems. So I think finally I will say my gratitude to the institute which I am standing here, that I came here and I witnessed some of the phenomenal, example or role model which is providing at the cost, some of the figures which Dr. Kamlakar told me, I don't know how you are competing, how are you surviving, delivering healthcare at that cost. So I think that really speaks the dedication of the staff here who I'm sure must be working at the salary which must be far below than the corresponding doctors, nurses and staff in other hospitals. So I think my gratitude and thanks to all of them. Thank you very much.
వ్యూస్ యూట్యూబ్ ఛానల్లో లైక్ చేయండి, షేర్ చేయండి, సబ్స్క్రైబ్ చేయండి.